My name is Dr. Monica Gandhi. I'm a professor of medicine at UCSF, and today I'm going to talk about the updates from IDWeek 2021. So one of the biggest updates that we had from the conference was the 144-week analysis of the switch to dolutegravir 3TC 2-drug regimen. So essentially, the TANGO study is looking at staying on a 3 to 4 drug TAF-based regimen versus switching to dolutegravir 3TC. And the randomization occurred, as you can see here on this slide, for patients who had no prior virologic failure, no history of NRTI or NCI resistance, and then either continuing TAF-based heart or switching. And this is the week 144 analysis. You can see that even out to 2 years, that there is a persistent virologic efficacy of the strategy of dolutegravir 3TC, 86% effective versus the TAF-based regimen. And that stayed persistent over the entire period. But what about side effects, adverse effects? Well, interestingly, the overall weight gain was similar in the two groups. It was about 2 kilograms if you were on the TAF group, or if you switched over to dolutegravir 3TC. However, importantly, if you started out obese, in the obese category in terms of your BMI, the weight gain was more pronounced with the TAF, staying on the TAF-based regimen. And that can be seen as the left-hand columns here on the right graph. And so essentially, if start out with a high BMI, more weight gain in staying on the TAF-based regimen. Now, in terms of this weight gain issue, the other the trial that gave us some insight into this is the DISCOVER trial. Now, remember, the DISCOVER trial was the pre-exposure prophylaxis trial that looked at TDF-FTC versus TAF-FTC. And now we have out to 144-week data presented at IDWeek. And you can, this is specifically looking at weight change in being on the TDF-FTC arm versus the TAF FTC arm. And you can see that, as we've been seeing in a number of studies now, TDF-FTC actually showed weight loss at 48 weeks and less weight gain than TAF-FTC out to 96 weeks. The difference was 0.5 kilograms in the TDF-FTC arm versus 1.7 kilograms in the TAF-FTC arm. So definitely more weight gain with the TAF-FTC arm, and actually more favorable lipids, at least in terms of an LDL change in the TDF-FTC arm. And you can see here the absolute weights on the graphs shown here. So this also led to another study that was presented at IDWeek in a poster format, which looked at essentially this very important question at this point in the HIV epidemic about what is happening with TDF-FTC versus TAF-FTC in terms of weight gain. And so this was a meta-analysis of 7 clinical trials, almost 20,000 people without HIV, where there isn't confounding by integrase inhibitors. And this was all the different PrEP trials that had looked at TDF-FTC. And essentially, there is an overall weight loss component of taking TDF-FTC. In fact, the odds ratio of weight loss was 1.44 across all of these PrEP trials in HIV-negative individuals. So there's definitely an association of TDF-FTC with weight loss. The next update that we saw from IDWeek was with a very important and exciting HIV medication that we're all looking towards, which is lenacapavir. This is a novel class of medications. This is the only capsid inhibitor of its type. And essentially, the capsid inhibitor is looking at the question of after viral assembly has occurred and the virus is budding out from the virus, it's essentially inhibiting the viral capsid formation around it. So this is the importance about lenacapavir is it has a very long half-life, which has some exciting possibilities of being paired with other long half-life medications for less frequent ART. And so what we saw at the IDWeek update is in the Calibrate study. Now, remember, the Capella study is the treatment experienced in MDR HIV study. The Calibrate study is a small study, but it's in treatment naive individuals. And there are 4 arms of the Calibrate study, and they are all looking, except for the comparison arm, which is the treatment group 4, before, which is BIC, TAF, and FTC, they're all looking at a combination of lenacapavir with different combinations as the backbone, either FTC, TAF, or eventually just bictegravir alone with lenacapavir. Now, the top three are all looking at lenacapavir, but the treatment group 3 is oral, and treatment groups 1 and 2 are lenacapavir subcutaneous. And importantly, how often is subcutaneous lenacapavir given? Every 6 months. So this really is the longest half-life that we have, and the possibility of giving ART at the least frequent dosing. So what did the study show us? Well, we already had the results from the Calibrate trial in terms of virologic suppression that showed us that the groups 1 and 2, which are lenacapavir subcutaneous every 6 months, at least out to the first 6 months, looked good and had high rates of virologic suppression. But what about happens if you fail lenacapavir? And what IDWeek showed us is in the Calibrate trial, there was a single participant who emerged lenacapavir resistant. They actually first emerged M184V, which left them less protected with the backbone of TDF-FTC. And then, though the lenacapavir is given directly observed, of course, the TAF-FTC is not. And there was an emergence of a lenacapavir mutation. So it can happen and needs to be watched out for. And specifically, the capsid inhibitor mutations are Q67H and K70R. Okay, another important study from IDWeek was actually looking at the response in people living with HIV to COVID-19 vaccination. There have been now quite a number of studies that show us that people with HIV are more at risk for severe disease with COVID, so vaccination is really imperative. So all of those studies in the past, at least at the beginning, we thought HIV wasn't a risk factor for more severe COVID, but at this point, the data has really emerged from the WHO, from a big study in the UK, New York State, that people with HIV have more severe outcomes with COVID. The reason that's so important is vaccination, of course, is crucial. So this study essentially took 100 patients with and without HIV at San Francisco General Hospital in San Francisco, and had laboratory samples that were drawn from routine care and had the time of COVID-19 vaccine administration, and essentially measured and compared IgG levels to COVID-19 vaccines to in those with and without HIV, as well as a surrogate virus neutralization assay. And the main findings of this study, by the way, 25% got Moderna and 75% got Pfizer, but they were all mRNA vaccinations. And the median CD4 count of the participants in this study was 511, and most patients were virologically suppressed. So in this study, most had an IgG response, but the IgG response was lower among people who lived with HIV, about 43% lower IgG titers. And the surrogate virus neutralization assay, there was a higher rate, 2.4 higher odds of non-response among people living with HIV than people without HIV. So it shows that people with HIV had a lower serologic response. T-cell assays are actually ongoing. And so what were the risk factors for having a lower and a serologic response to COVID-19 vaccination in HIV patients? It was having an unsuppressed HIV viral load and having a lower CD4 count of especially less than 200. And also receiving the Pfizer vaccine versus the Moderna vaccine. So definitely lower responses in the vaccine with a 30 microgram dose of Pfizer, and also Pfizer is given at a lower dosing duration interval than Moderna. So it does support the strategy of third doses for people living with HIV as a booster for your booster. And this, of course, this idea that Pfizer has been giving a lower response than Moderna because of the lower dose and 3 weeks between spacing versus 4 weeks between spacing is actually shown in other big trials, even among those who aren't living with HIV. This is a big study from the CDC across general populations, and Moderna was holding 93% protection against hospitalization in Delta, Pfizer 88%, and Johnson & Johnson 71%. Okay, and then the final study I want to highlight at IDWeek is really about an important medication that's now just been approved by the FDA, which is molnupiravir. What is molnupiravir? Its mechanism of action against COVID-19 is actually a nucleoside analog. It's a ribonucleoside prodrug. It has broad antiviral activity against other RNA viruses. It was not developed for SARS-CoV-2. It resembles like an NRTI and HIV. And essentially, we had a lot of preceding studies that showed that molnupiravir was going to stop viral replication in SARS-CoV-2, but some of the studies that came out at IDWeek showed that sort of the mechanism of action of how molnupiravir induces RNA immunogenesis and stops viral replication. And so what did we see right on the Thursday of the IDWeek conference? Because actually it was presented sort of outside of IDWeek, was the Move Out trial. Another IDWeek trial, again, showing the mutagenic potential. Okay, so what did we see at IDWeek? So a couple of updates. Molnupiravir, when given in the phase 2 trials, showed quite a rapid reduction in viral load of SARS-CoV-2 when given at doses even of 200 milligrams, but the viral load went down most strongly at 800 milligram dosing. So this is actually the dose that's chosen for molnupiravir, 800 milligrams twice a day. And importantly, because molnupiravir works upstream of producing the virus, of producing the spike protein, for example, of the virus, it works equally well against all the variants, including Delta. And so the news release occurred in conjunction with the timing of IDWeek of the investigational oral phase 2B trial of which is called Move Out, and then phase 3 study Move Out. This is outpatients who are at risk for proceeding to severe SARS-CoV-2 infection. They are unvaccinated and they have mild to moderate COVID. And essentially placebo versus molnupiravir, 800 milligrams POBID for 5 days. And the interim analysis was presented at IDWeek, which showed a 50% reduction in hospitalization and death with the administration of molnupiravir versus placebo. Now, importantly, there was an updated analysis presented to the FDA before they reviewed molnupiravir for approval. And when the study went out to include all 1,443 patients, the benefit was reduced to a 30% reduction in hospitalizations and deaths from molnupiravir. Nonetheless, it's an important medication that was approved by the FDA for use in our unvaccinated patients at risk for severe COVID-19. Do remember, and this was not at IDWeek, but just to remind you all that molnupiravir is not a drug that has been approved or is useful in hospitalized patients. By that time, the inflammation has really taken on its big role, and there was no efficacy in the move-in trial of molnupiravir for inpatients. And then I will end with a new and interesting medication for Staph aureus bacteremia. We always need medications for Staph aureus bacteremia, especially MRSA. This is Exebacase, which is a bacteriophage lysine that has antimicrobial, anti-staphylococcal direct-acting lysine activity. And we had a direct human study that was published previously the year before that looked at the fact that in patients with Staph aureus bacteremia, that this drug was essentially randomized to standard antibiotics for Staph aureus bacteremia. And what we saw that is with 116 patients with Staph aureus bacteremia and who were treated and analyzed, and 71 had gotten the new medication, there was a modest improvement in day 14 clinical recovery. But it's important to note, as shown on the slide on the right, that the improvement was really only in patients with MRSA bacteremia. So at day 14, 70% versus 60% recovery. But among those who have MRSA bacteremia, 74% recovery with Exebacase versus the standard of care alone. So maybe a new drug in the future for a MRSA bacteremia specifically. And I will end there with updates from IDWeek. Thank you very much for your attention.